That means what are the signs and symptoms of depression and what causes depression. And we'll also discuss regarding the treatment of depression. Clear? And later we'll also discuss regarding uterine stimulants as well as uterine relaxants. Am I clear? So first let's start with depression. So what is this depression? Depression, it is nothing but a clinical condition where person he'll be having disorder of mood. There will be mood disorder. Am I clear? So in depression, what actually happens is, let me show you. See, for example, this one is your normal mood. Okay, this one is your normal mood. Okay, so what happens here is, see, normally sometimes you'll be a little bit happy, you'll be a little bit sad, right? This is normal. Sometimes you'll be happy, sometimes you'll be sad because of small things. Okay, what happens is, for example, if your friend is eating 2 chocolates at a time without giving you, that time you'll be having, you'll feel very, very sad. Am I clear? If your dad, if he buys you a teddy bear, then you'll be very, very happy. Am I clear? So, normal mood this is when your friend, sometimes you'll be sad, sometimes you'll be happy. All these are normal. Okay? When you hear a good news, you'll be happy. When you hear a bad news, you'll be sad. Once your friend, once she bought 2 chocolates and all the 2 chocolates, if she is eating, then you'll feel very, very sad. Clear? If your dad buys you a teddy bear, then you'll be very, very happy. Clear? Am I clear? This is all normal. Clear? And if your mood swings in this direction, this is called as depression, where there will be mild to moderate depression. Mild to moderate depression occurs over here. See, in this what happens is, this is a deadly triangle where person will be having hopelessness, helplessness, and he will also be having anhedonia, N-I-A. Clear? Anhedonia is a condition where person could not, he will be having inability to enjoy the little things in his life. He doesn't feel happy at all. Okay, that condition, he could not enjoy the day-to-day activities or day-to-day small things that can happen in his life. Okay, there is nothing but anhedonia. Am I clear? And say this is mild to moderate depression. Once you fail in your exam, you'll go into a state of mild to moderate depression. Am I clear? Am I clear? This is all common. Am I clear? And you can get out of this by using drugs. Am I clear? And sometimes what happens is, you will be in severe depression. Severe depression occurs. Person will be having delusions. He will be having suicidal tendencies or thoughts. Okay, this is what happens in severe depression. Am I clear? And once you get a good job, then what happens is, you will be in the state of hypomania. Am I clear? You will be in a state of hypomania. Clear? And if you get a good job and make a lot of money, then you will be at a state of mania. You'll spend a lot of money, lavishly you'll be spending. That condition is called as mania. Clear? Now, coming to the types of depression, we have got 3 types of depression, although we have 4. Okay, I'll explain. One is unipolar depression. In this unipolar depression, what happens is your mood swings in a single direction. That means your mood will swing like this side. Clear? Your mood, it will swing like this. Clear? In unipolar depression, 80% of the people who are suffering with depression, they come under unipolar depression. Am I clear? In this depression, what happens is the mood, it swings in a single direction. Am I clear? And this depression, there will be either person will be feeling worthlessness. Am I clear? He will feel he is worthless, or there will be groundless irritability. Easily he will be irritated. Am I clear? This is regarding unipolar depression. Clear? Now coming to the second one, which is bipolar depression. Bipolar depression, what happens is your mood swings like this. Am I clear? In both the directions it swings, person will be having depression followed by mania. Okay, in a cyclical manner, it goes depression followed by mania. Am I clear? So this kind of depression, it is called as mania depressive psychosis. MDP stands for mania depressive psychosis. Am I clear? See, 60 to 70% of people who are having unipolar depression, they will have symptomatology of reactive depression, which is characterized by person will be feeling, he'll be feeling sad, he'll be having grief, he'll be having anxiety. Am I clear? He'll be feeling sad, he'll be having grief, he'll be having anxiety. This occurs because of bereavement of loved ones, because of unemployment it can occur, because of any kind of physical illness it can occur. Am I clear? As well as because of social problems also it can occur. Clear? Next is this, it can be treated. Am I clear? This, it can be treated by giving anti-anxiety drugs. Anti-anxiety drugs like alprazolam. Clear? So, drug alprazolam can be used to treat. Am I clear? Next is 30 to 40% of unipolar depressed cases, they are having endogenous depression. Clear? Endogenous is within. Am I clear? There is no age limit for this. Am I clear? It can occur at any age. Am I clear? Endogenous depression, it can occur at any age. Am I clear? There is no limit. Okay. These people, they can be treated with, unless and until you treat these people with antidepressants as well as electroconvulsive therapy you can give for the treatment of people who are having unipolar depression, okay, and who are having endogenous depression. Okay, unipolar depressed people, they are endogenously depressed with suicidal thoughts. They'll be having suicidal thoughts, suicidal tendencies occur in them, hallucinations, delusions occur in them. Clear? You can treat those people by using antidepressants or electroconvulsive therapy. Am I clear? This is clear, right? So, the depression types, unipolar, bipolar, reactive depression. We have reactive depression is also called as exogenous depression. Person will be, he'll react to something. If he misses his loved ones, or if his loved ones dies, or because of unemployment, am I clear? It can lead to depression, or any kind of social problems if he is having, it can lead to depression. Am I clear? As well as this endogenous depression. Endogenous depression can be occurring at any age. It is not self-limiting, my dear students. Whereas reactive depression or exogenous depression is self-limiting. Am I clear? This endogenous depression, it can be treated by giving drugs like antidepressants as well as electroconvulsive therapy. Am I clear? And these are all the types of depression, guys. So, what is the cause of depression? Say, depression can occur because of reduced functional activity of norepinephrine, dopamine, as well as serotonin. Or simply, you can say it occurs because of decreased functional activity or functional deficit of norepinephrine, serotonin, or both, as well as dopamine. Am I clear? And recent evidence states that there is a factor called as brain-derived neurotropic factor. This brain-derived neurotropic factor is a growth factor which helps in neural plasticity. Plasticity in the sense helps in new connections between the neurons. Am I clear? As well as it helps in neurogenesis. Am I clear? So, due to the lack of this nerve growth factor, nothing but the brain-derived neurotropic factor, what happens is the neurogenesis stops, neural plasticity reduces, gaps between the neurons will increase. Am I clear? As well as there will be decrease in the volume of hippocampus as well as prefrontal cortex. Am I clear? If the person is depressed, what happens is there will be reduction in the volume of prefrontal cortex as well as hippocampus. Am I clear? Am I clear? Next is, if you are using antidepressants, then what happens is, if the person is treated with antidepressants, the levels of brain-derived neurotropic factor will increase, as well as the volume of prefrontal cortex will increase, as well as your hippocampus increases. Clear? Next is coming to other factors, endocrine factors that can lead to depression are increase in your adrenal gland size can lead to depression, and any abnormalities in your HPA axis, that is hypothalamo-pituitary adrenal axis. If there are any kind of abnormalities, it can lead to depression. Any abnormalities in the thyroid functioning, any thyroid abnormalities if you're having, as well as any sex steroid abnormalities if you have, it can lead to depression. Am I clear? When your levels of cortisol as well as corticotropin releasing hormone levels increases, it can lead to depression, my dear students. If there is decreased level of growth hormone, also it can lead to depression. Increased prolactin levels also can lead to depression. Clear? So these are all the factors which can lead to depression. In depression, there will be reduced functional activity of norepinephrine, serotonin, or both, as well as decreased functional activity of dopamine, as well as there will be decreased nerve growth factor, nothing but brain-derived neurotropic factor. Okay? There will be decreased brain-derived neurotropic factor. The volume of prefrontal cortex as well as hippocampus, it reduces. And because of increased levels of cortisol as well as corticotropin-releasing hormone, depression can occur. Any abnormalities in the HPA axis or thyroid functioning or sex steroids can also lead to depression. Decreased growth hormone levels can lead to depression. Am I clear? Increased prolactin levels can also lead to depression. So all these factors, they contribute to depression. So how do we treat it? Let's see. Okay, what are the drugs that we can use? We'll discuss. As you can see over here, coming to the introduction, various hypotheses have been proposed for the pathogenesis of depression. If the levels of norepinephrine or 5-hydroxytryptamine or serotonin or both, once it reduces, as well as dopamine levels reduces, so the functional activity of all these, they reduce in your cortical as well as limbic system, it can lead to depression, my dear students. Clear? And if, as we have already discussed, the nerve growth factor, if it is decreased, brain-derived neurotropic factor, which helps in neuroplasticity as well as neurogenesis. If it reduces, it leads to depression. Clear? Next is any abnormalities in the HPA axis or thyroid function or sex steroids. These all factors, they cause depression. They can lead to depression. Clear? So what you can do? Do the opposite. Say the functioning of what is going on? There will be decreased levels of or decreased functioning of monoamines occurs, right? So increase their activity or their functioning. If you increase the activity of especially these neurotransmitters like norepinephrine, dopamine, as well as 5-hydroxytryptamine. Once you increase, then what happens? Person will not be depressed, he will be normal. Okay, so we have drugs which can increase the levels of these neurotransmitters, guys. So coming to the classification, as you can see, we have got TCAs, tricyclic antidepressants. Am I clear? These tricyclic antidepressants, they themselves, they're saying, to remember the mnemonic, I'm giving this, they themselves are saying, try me. Okay, they're saying, try me. So the drugs are trimipramine, imipramine, clomipramine, amitriptyline, doxepin, dothepin, desipramine, nortriptyline, protriptyline, amoxapine, maprotilin, reboxetine. Next, coming to SSRIs. As the name itself says, selective serotonin reuptake inhibitors. Fluoxetine, fluoxamine, paroxetine, sertraline, citalopram, escitalopram, dapaxetine. Remember, my dear students, here, as you can see over here, this desipramine, nortriptyline, protriptyline, amoxapine, maproxetilin, as well as reboxetine, these drugs, they mainly act by inhibiting norepinephrine reuptake. Am I clear? As well as these last three drugs, amoxapine, maprotilin, as well as reboxetine, these are newer antidepressants. Am I clear? Next, coming to SSRIs, we have got, as we have discussed, fluoxetine, fluoxamine, paroxetine, sertraline, citalopram, escitalopram, dapaxetine, out of which escitalopram, it is 100 times more potent when compared to citalopram. Clear? Next, we have got SNRIs, selective serotonin norepinephrine reuptake inhibitors. We have got venlafaxine, duloxetine, milnacipran. Next, we have got atypical antidepressants. We have got trazodone, mycin, mirtazapine, bupropion, tianeptine, epinephrine, atomixtin. REMAS, reversible inhibitors of monoamine oxidase. Monoamine oxidase is an enzyme, my dear students. These drugs, they are reversible inhibitors of monoamine oxidase. Say monoamine oxidase, it is of two subtypes or two isotypes, MAO A, MAO B. Am I clear? MAO A, as the name itself says, it contains A. So remember like this: A for all. It is present in almost all the organs. Am I clear? It is present in your brain. It is present in your GIT. It is present in your liver. Almost everywhere it is present. Am I clear? Whereas MAO B, B for B, you can remember it is present in your brain. Am I clear? Am I clear? Next is MAO A. MAO A, again A for all. It metabolizes all the catecholamines, especially norepinephrine, dopamine, adrenaline, as well as it also metabolizes 5-hydroxytryptamine and histamine. Clear? So for today's class, for the time being, you just remember that MAO A, it mainly inhibits. MAO A is an enzyme, monoamine oxidase. Type A is an enzyme which inhibits or which metabolizes dopamine, noradrenaline, as well as serotonin. Clear? Whereas MAO B, it mainly inhibits or it predominantly inhibits dopamine. Am I clear? So inhibits in the sense metabolizes. Clear? So both A and B, they equivalently metabolize dopamine. Am I clear? Whereas MAO A, it mainly metabolizes dopamine, 5-hydroxytryptamine, as well as norepinephrine. Clear? So we have got REMAS. We have got meclobamide, chlorgalin. REMAS are nothing but reversible inhibitors of monoamine oxidase type A. We have got type B also, drugs, selzilin, rasazilin. These drugs, they inhibit MAO B. Am I clear? Say, remember, how to remember, for this the mnemonic is MAC. MAC is the mnemonic. MAO A inhibitors, you can remember, or REMAS, you can remember by the mnemonic MAC. M for meclobamide, A for MAO A, C for chlorgalin. Am I clear? MAO B inhibitors, we have got selzilin, rasazilin. Clear? See, if you are giving at low doses selzilin, then selzilin, what it does is it metabolizes MAO B, or it inhibits. It inhibits MAO B. Okay, clear? If you are increasing the doses, then it has got non-selective action. That means it inhibits both MAO A as well as MAO B. Clear? But such doses cannot be tolerated by human beings. But nowadays, we have got transdermal patch of this selzilin, which is a MAO inhibitor, which can be used to treat depression. Normally, these two drugs can be used for depression. Nowadays, transdermal patch of selzilin is available in the market, which is helpful for the treatment of depression. Clear? This is clear, right? Next is coming to the TCAs. As you can see over here, see, for example, as you can see over here, this is your presynaptic neuron. Am I clear? This is your effector cell. Am I clear? Am I clear? Now, what happens is norepinephrine, once it is released, it acts on the receptors which are present on the effector cells. Once the action is complete, it will be reuptaken back by NET. NET stands for norepinephrine transporter. Am I clear? Once norepinephrine is released by the process of exocytosis, it acts on the receptors which are present on the effector cells. Once the action is complete, it will be reuptaken back into the presynaptic terminal by norepinephrine transporter. TCS block this norepinephrine transporter. Then what happens? Norepinephrine cannot be reuptaken back. So the reuptake process will be inhibited. So more norepinephrine can act on these receptors. Am I clear? Next is, this whole process is regarding the adrenergic neurons. Am I clear? Am I clear? Next is, now coming to serotonergic neurons. What happens is, this serotonin or 5-hydroxytryptamine, which is released by the process of exocytosis, it acts on the receptors which are present over here. Am I clear? 5-HT2 receptors. These are 5-HT2 type of receptors. These receptors, they can be alpha 1, alpha 2, beta 1, beta 2. Clear? So once the action is complete, this will be reuptaken back by SERT. Serotonin transporter will reuptake. It will be helpful for the reuptake of this 5-hydroxytryptamine, my dear students. Am I clear? Is that clear? So once you're blocking this, then what happens? Once you're blocking this serotonin transporter, then what happens? More and more serotonin can act on its receptors. Am I clear? Next is this TCAs, they also decrease dopamine reuptake. Am I clear? Dopamine reuptake also will be inhibited by tricyclic antidepressants. Clear? These TCAs, they have muscarinic blockade activity. Clear? They block muscarinic receptors. That means it has got atropine-like actions. Am I clear? Atropine-like actions are nothing but, remember the mnemonic, B for blurred vision. Am I clear? C for constipation. Am I clear? B for blurred vision. C for constipation. D for dry mouth. G for precipitates glaucoma. Because this it has got atropine-like actions, right? So what it does is, it causes mydriasis. Mydriasis is dilation of the pupil. Am I clear? It causes relaxation of your ciliary muscle. Am I clear? Which leads to occlusion of your canal of Schlemm. Am I clear? So that the drainage of aqueous humor will not occur, and it leads to precipitation of glaucoma. Clear? So B, C, D, G is the mnemonic over here. Am I clear? Blurred vision, constipation, dryness of mouth, G for precipitates glaucoma. Clear? So these are all the actions of TCAs by blocking muscarinic receptors, or because of muscarinic blockade, all these actions occur. Clear? Next is, they cause alpha 1 blockade. TCAs, they cause alpha 1 blockade. Once alpha 1 is blocked, see my dear students, always remember ABCD is very important in pharmacology. A, B, C, D. A is the first alphabet, B is the second alphabet. So alpha 1 causes vasoconstriction. Beta 2 causes vasodilation. Clear? If I'm blocking this one, then what happens? If I'm blocking this alpha 1 blockade leads to decrease BP, right? Decreased BP occurs, because of which the reflex activity, postural hypertension can occur, right? The opposite action is tachycardia can occur, as well as reflex tachycardia can occur. And the norepinephrine, which is released, it can act on beta 1 receptors. Am I clear? Because of which there will be tachycardia as well as cardiac arrhythmias can occur. So these are the adverse effects. Clear? These TCAs, they block H1 receptors. Remember, my dear students, this H1 histamine, once it acts on H1 receptors, it leads to increased wakefulness and decreases appetite. It blocks the appetite. Am I clear? Once if you're blocking these receptors, histamine cannot act, so it can lead to sedation, confusion, increased appetite. Am I clear? This is clear, right? Next is TCAs. They decrease the seizure threshold, which can precipitate convulsions. Because of this, as they are reducing the seizure threshold, then what happens is it leads to convulsions, my dear students. Precipitation of convulsions are clear. So these are all the actions of TCAs. TCAs, what they do? They cause inhibition of, or they inhibit the uptake of dopamine, norepinephrine, serotonin. Am I clear? They cause alpha 1 blockade. They cause muscarinic blockade. They have got H1 blockade as well as they precipitate seizures. Am I clear? This whole concepts are clear, right? Next, coming to the mechanism of action of SSRIs, selective serotonin reuptake inhibitors. See, for example, this is the presynaptic neuron and this is the effector cell. Clear? Or the postsynaptic neuron. Clear? Now what happens is serotonin, which is present over here by the process of exocytosis, it will be released over here. Am I clear? (5-HT), it will be released over here and it will be acting on the receptors which are present on the postsynaptic membrane. Am I clear? Over here. Once the action is complete, they will be reuptaken back by SERT, as we have discussed before. That is selective serotonin reuptake inhibitors. They inhibit this serotonin transporter. Once serotonin transporter is inhibited, then serotonin uptake will not be there. There will be more and more action of serotonin in the synapse. Am I clear? So these drugs, they inhibit this serotonin transporter, blocks the uptake. Reuptake is inhibited, increases the availability of 5-HT at the receptors, as you can see over here. Clear? In the CNS, and enhances serotonergic activity, which reduces depression. Next is, we have got, this is the adrenergic or noradrenergic neuron. Am I clear? Once this neuron is stimulated, there will be release of norepinephrine, which can act on these receptors, the postsynaptic receptors. Am I clear? Once the action is complete, this will be reuptaken by norepinephrine transporter. Am I clear? This will be inhibited by SNRIs. As the name itself says, selective serotonin norepinephrine reuptake inhibitors. These are. Am I clear? So they cause inhibition of night, because of which norepinephrine will not be reuptaken back. It will be available in the synapse, which can act on the postsynaptic neurons. Am I clear? Or postsynaptic receptors. Clear? As well as, for example, this is the serotonergic neuron. Serotonin, it will be released. Once it is released, this serotonin, it acts on the postsynaptic receptors. Once the action is complete, it will be reuptaken back by serotonin transport, which will be also inhibited by these drugs, SNRIs. Am I clear? So, because of inhibition of reuptake of serotonin as well as noradrenaline, depression will be reduced. Because of inhibition of reuptake of both this norepinephrine as well as serotonin, what happens is there will be more availability of serotonin as well as norepinephrine in the synapse, because of which they can act on the receptors and the function can be increased, which reduces depression. Clear? Bupropion, what it does is, this drug, it inhibits the uptake of dopamine, 5-hydroxytryptamine, as well as norepinephrine into the neuron. So once the reuptake, same like this process, dopamine, for example, take this is the dopamine receptor. Okay, and we have the dopamine over here. Once it is released, dopamine acts on dopaminergic neurons and it will be reuptaken back by dopamine transporter. Once this transporter is inhibited, reuptake will be inhibited. Dopamine will stay over here, more action on the postsynaptic neurons, the receptors of postsynaptic neurons. Am I clear? That's how bupropion acts. Next is this drug, mirtazapine. Mirtazapine, what it does is, here, see here, you are having, this is the noradrenergic neuron. This is the serotonergic neuron. Am I clear? We have got noradrenaline or norepinephrine. Am I clear? Here we will be having two types of receptors, my dear students. One is called as alpha-2 receptors. This one is called as 5-HT1 type of receptor. See, this neuron is, this whole neuron, it is noradrenergic neuron, and the receptors are alpha-2 receptors, which are autoreceptors. Auto is self. Am I clear? So these receptors, they are autoreceptors. Whereas these receptors, that is 5-HT1 type of receptors, these are called as heteroreceptors, my dear students. Clear? Next is this serotonergic neuron. This, from here, serotonin will be released. Am I clear? This, it contains two types of receptors, the same alpha-2 as well as 5-HT1 type of receptors. Am I clear? This is called as heteroreceptor. This, you call it as autoreceptor. Am I clear? Now, what happens is, this mirtazapine, what it does is, this drug, it blocks heteroreceptors, that is, the receptors which are present on these neurons will be blocked. These are also blocked. These are also blocked. All these are blocked. Once all these are blocked, then what happens? There will be more and more release. See, remember, once the receptors are presynaptic receptors, stimulation of presynaptic receptors inhibits the release of the neurotransmitter. Once you're blocking these receptors, presynaptic receptors, whether auto or heteroreceptors, once they are blocked, what happens? There will be increased release of neurotransmitter, my dear students, because of which there will be more and more release. Am I clear? Is that clear? See, they block alpha 2 autoreceptors, which are present on presynaptic noradrenergic neurons, as well as they also block heteroreceptors, which are present on noradrenergic neurons. They also block autoreceptors, which are present on 5HT2, 5HT1 autoreceptors, which are present on serotonergic neurons. They also inhibit heteroreceptors, nothing but alpha 2 receptors, which are present on serotonergic neurons. Once the blockade occurs, once the presynaptic receptors are blocked, once these presynaptic receptors, once they're blocked, then what happens? There will be more and more release of neurotransmitters. Am I clear? Because of which there will be increased activity of norepinephrine as well as 5-hydroxytryptamine. Clear? As well as these drugs, they do block H1 as well as 5HT2 C type of receptors. Remember, my dear students, 5HT1A and 5HT1B, they regulate your mood and they regulate your behavior. Okay, stimulation of action of serotonin or stimulation of these receptors or action of serotonin on these receptors, it regulates your mood, it regulates your behavior. Clear? 5HT1D type of receptors, they cause vasoconstriction of your cerebral blood vessels. Clear? Is it clear? Next is 5HT2A causes vasoconstriction. Am I clear? As well as smooth muscle contraction. Clear? This is clear, right? Remember this. Next is atypical antidepressants. Bupropion, it inhibits the reuptake of dopamine, serotonin, as well as norepinephrine into the neurons, because of which there will be increased activity. Clear? We already discussed about metrazepam, right? We also discussed about bupropion. Hope this slide is clear. Next is trazodone. Trazodone, what it does is it blocks 5-hydroxytryptamine or serotonin reuptake. Once it is not reuptaken back, then there will be more and more activity of serotonin at the synapse, clear, or on the post-synaptic receptors, clear? And it also acts as a blocker of 5HT2A receptors, and it also blocks alpha-1 adrenergic receptors, clear? Next is myosin. Myosin, it inhibits the presynaptic alpha-2 autoreceptors, which are present on the noradrenergic neuron. For example, this is the noradrenergic neuron. There is a receptor called as alpha-2 autoreceptor. This is autoreceptor because the neuron is noradrenergic neuron. Clear? Once this is blocked, more and more release of norepinephrine occurs, which leads to more and more action. Clear? Slide is clear, right? So where you can use all these antidepressants? You can use in cases like depression. To treat depression, you can use SSRIs. In anxiety disorders, also you can use SSRIs. Of course, you also can use SNRIs. In obsessive compulsive disorder, OCD, you can use TCAs. As well as you can also use SSRIs. In attention deficit hyperkinetic disorder, you can use TCAs, my dear students. Am I clear? In nocturnal enuresis, bedwetting, you can use TCAs. Prophylaxis of migraine, you can use amitriptyline, which is a TCA. Clear? Chronic pain, including neuralgias, you can use TCAs, you can use SNRIs. Clear? In atopic dermatitis, to prevent this, doxepin can be used because it has got antipruritic action. Premature ejaculation, person is ejaculating within 5 seconds or 10 seconds. In those conditions, you can use dapoxetin. Clear? Tap. Okay, once you tap the penis, ejaculation doesn't occur. Clear? Remember like that. Tap. Dapoxetin, if you're giving 1 hour before sexual intercourse, then it inhibits premature ejaculation. Clear? Just clear, right? Coming to the adverse effects, TCAs, as we already discussed, because of muscarine blockade activity, we also discussed the mnemonic, right? B for blood vision, atropine-like side effects, right? Blood vision, constipation, dryness of mouth, as well as it precipitates glaucoma. Alpha-1 adrenergic blocking activities, which leads to hypertension, reflex tachycardia can occur, right? As well as cardiac arrhythmias because of stimulation of beta-1. H1 blockade leads to sedation, confusion. Am I clear? As well as increased appetite. Am I clear? And TCAs, they can also cause, by reducing the seizure threshold, they can cause precipitation of seizures. Am I clear? Precipitation of convulsions. Clear? Or seizures can occur. Clear? Next is SSRIs. SSRIs, they have got nausea, they cause GI symptoms like nausea, vomiting, diarrhea, insomnia, sexual dysfunction, impotence, loss of libido. These all occur, adverse effects, they occur because of, that is, sexual dysfunction, impotence, loss of libido. They occur because of increased activity of serotonin at the level of spinal cord and above. Because of increased activity, sexual dysfunction, impotence, loss of libido occurs. SSRIs as well as SNRIs, they don't inhibit, they don't block this H1, they don't block muscarinic receptors, they don't block alpha-1 receptors. Remember this, my dear students. Because of which SNRIs, they cause nausea, vomiting, sexual dysfunction, especially because of lack of this alpha blockade. They don't block alpha-1 receptors. Am I clear? Because of which sexual dysfunction, anxiety, hypertension can occur. Clear? Am I clear? Next is bupropion. Bupropion, it causes dryness of mouth, tremors, sweating, convulsions can occur at high doses. Mirtazapine, it can block, as we already discussed, H1 receptors. It's a H1 receptor blocker as well as 5-HT2C block, right? Which we have already discussed over here. Can you see it? This one. Am I clear? So, as these receptors, they are blocked, then what happens? Because of the blockade of these receptors, it can lead to, mainly because of H1 blockade, it can lead to sedation. It can lead to increased appetite. It can lead to weight gain. Clear? Trazodone, it causes sedation, hypotension, as well as priapism, painful erection of the penis occurs. Clear? Next is myanserin. Myanserin, what it does? See, trazodone, as we already discussed, how it is causing hypertension because of blockade of alpha-1. Priapism is also, painful erection of the penis is also because of alpha-1 blockade, my dear students. Next is myanserin. Myanserin, it precipitates seizures. It has got anticholinergic and cardiac side effects, and it also causes sedation. Am I clear? At high doses, it can precipitate seizures. Clear? This is clear, right? Next, coming to drug interactions. If you're giving TCAs along with concomitant administration of TCAs along with MAO inhibitors, along with alcohol and CNS depressants, TCAs, what they do, they potentiate the effect of indirectly acting sympathomimetics because they inhibit the reuptake of norepinephrine, dopamine, as well as serotonin. Am I clear? So they potentiate the effect of directly acting sympathomimetic agents. Am I clear? Because directly acting sympathomimetic agents also cause stimulation of receptors. Clear? Am I clear? Next is, if you are using MAO inhibitors, then it can lead to hypertensive crisis, hyperpyrexia can occur, convulsions can occur, coma can occur because of decreased metabolism of thiamine. Clear? If you are giving alcohol plus or alcohol and CNS depressants, if you are giving, there will be potentiation of CNS depressant effect. See, low doses of alcohol, they stimulate your CNS, my dear students. If you're drinking too much, then it leads to CNS depression. Clear? That's the reason you fall asleep. Clear? Next is, if you're combining SSRIs and MAO inhibitors, then what happens is there will be increased activity of serotonin, which can lead to tremors, restlessness, muscle rigidity, hyperthermia, sweating, shivering, seizures, as well as coma. This condition you call it as serotonin syndrome, my dear students. So serotonin syndrome occurs mainly because of combination. If you're giving combination of, or if you're combining SSRIs with MAO inhibitors. Clear? If you're giving SSRIs along with TCAs or antipsychotics or beta blockers, phentoin and carbamazepine, then what happens is this SSRIs, these are inhibitors of metabolizing enzymes. They inhibit the metabolizing enzymes, because of which the drugs will not be metabolized. All these drugs like TCAs, beta blockers, antipsychotics, carbamazepine, phentoin, these are not blocked. Their metabolism is not blocked. Am I clear? What I mean to say is, SSRIs, they inhibit metabolizing enzymes. Once metabolizing enzymes are inhibited, there won't be any enzyme to metabolize these drugs. So these drugs will not be metabolized. Then what happens? Plasma levels of these drugs will increase. Clear? This slide is clear, right? Next, coming to cheese reaction. See, my dear students, if you are eating cheese, if you are eating fish, if you are eating meat, if you are drinking beer, if you are drinking wine, if you are eating yeast, all these, they contain thiamine. These foods, they contain thiamine. Normally, if you people and me, if we eat these foods which contain thiamine, thiamine enters into your GIT as well as to our liver. It enters, which will be there, it will be metabolized by monoamine oxidase enzyme. Am I clear? Especially type A. And in people who are having or who are taking MAO inhibitors, MAO A inhibitors, then what happens? MAO A will be inhibited. Once there is no MAO A, thiamine will not be metabolized. Am I clear? See, normally what happens is, in normal people, if you take foods rich in this thiamine, food rich in thiamine, then this thiamine, it will be metabolized inside your gut as well as inside your liver. Clear? Normally, in us, it will be metabolized by monoamine oxidase enzyme. In persons who are depressed, if they are using MAO inhibitors, then what happens? Monoamine oxidase will be inhibited. There won't be monoamine oxidase enzyme. If they are eating foods which contain thiamine, like cheese, red wine, beer, fish, meat, yeast, then what happens? MAO will not be there, so thiamine will not be metabolized. So thiamine level increases. Am I clear? So thiamine, it escapes degradation in the gut. Am I clear? In patients who are using MAO inhibitors, this thiamine, it reaches your systemic circulation, enters your noradrenergic neurons or noradrenergic nerve endings, and it causes, once, see here, actually the mechanism how it occurs is, see, this is the neuron. Am I clear? This is the presynaptic neuron. Am I clear? This is norepinephrine. Am I clear? Thiamine enters inside and it causes more and more release of norepinephrine. Am I clear? Once norepinephrine is more and more released, am I clear? It leads to increase in BP, leading to hypertensive crisis as well as cerebrovascular accidents. Clear? So this is all regarding cheese reaction. So how do you inhibit it? You can give phentolamine. IV can be given. IV phentolamine can be given. Am I clear? IV, which IV phentolamine can be given. Clear? Don't worry about my writing, guys. This is the first time I'm writing. So actually the software was not good. Okay. So just listen to the lecture. If you understand the basic concept, is enough. This is clear, right? So more and more release of norepinephrine occurs. Once more and more norepinephrine is released, it leads to increased BP, which leads to hypertensive crisis as well as cerebrovascular accidents. Clear? This is all regarding depression. If you want to learn more, subscribe to our channel. Subscribe to our app, Prakara. Clear? Next is ecbolics, also known as oxytocics. Now we'll discuss again drugs acting on the uterus, ecbolics. Nothing but oxytocics, nothing but uterine stimulants. These drugs, they cause stimulation of your uterus. We have drugs like oxytocin, we have got ergot derivatives, ergometrin or ergonovin. We also have methyl ergometrin or methyl ergonovin. We also have prostaglandins as well, prostaglandin analogs, PGE2, PGF2 alpha. We have got 15 methyl PGF2 alpha, which is having long duration of action and it is more potent when compared to PGF2 alpha analog. We have got PGE1 analog, which is misoprostol. Clear? See, my dear students, remember PG, for example, this is here, as you can see, this is this part. Am I clear? PGF2 alpha as well as PGE2. They are present on the fundus at this part. They are present. Am I clear? They cause contraction of the uterus. Clear? Prostaglandins, by acting on these receptors, which are present over here, am I clear? They cause contraction of the uterus. Am I clear? Whereas PGE1, it inhibits the contraction of the cervix. It causes relaxation over here. Am I clear? Is it clear? So remember, drugs or prostaglandins which can cause uterine contraction, which can cause uterine relaxation. First, we'll discuss regarding prostaglandins, PGE2 at low doses, PGF2 alpha Thromboxane A2, they cause uterine contraction. Whereas high doses of PGE2, PGI2, they cause uterine relaxation. I remember it inhibits uterine contraction, so it causes uterine relaxation. Am I clear? This is clear, right? Again, remember one more thing. PGE1 analog is misoprostol. Am I clear? PGE2 analog is dinoprostone. You got one more drug, dinoprost. Dinoprost is PGF2 alpha analog. How do you remember E for E? Am I clear? Dinoprostone. Am I clear? PGE2 analog is dinoprostone. Next is PGF2 alpha analog we have, which is carboprost. Am I clear? So how we can remember all these? Is there any mnemonic? You can easily remember, always your missus comes first, right? So PGE1 analog is misoprostol. Clear? During the time of pregnancy, because of the pain, she will be dying, right? Dying with the pain. I mean, she will be very in a painful condition, right? Then what you'll say? Don't die. So dinoprostol. Clear? Because you're taking her to the hospital and the hospital is far and you're taking her in a car. So PG, like this, you can remember F2, carboprost. E2, as you're saying, dino, okay? Dinoprostone. E1, your miss comes first. So misoprostol. You can remember like this. Clear? Now, say this oxytocin, it will be synthesized by your hypothalamus, especially your supraoptic and paraventricular nuclei of your hypothalamus. They cause secretion of oxytocin along with antidiuretic hormone. Am I clear? Which will be stored in your posterior pituitary. Am I clear? This oxytocin along with ADH, they can be stored in your posterior pituitary. Am I clear? Now, this oxytocin, it should be released. So, coming to these stimulants, which cause release of oxytocin from the posterior pituitary are parturition, that is during labor at the time of childbirth. Once you are stimulating the nipple, then it can lead to release of oxytocin, my dear students. Remember this. Am I clear? And during suckling, when the baby is suckling the milk, okay, that time oxytocin will be released, as well as during coitus, during sexual intercourse, also oxytocin is released. The more a man satisfies a woman, the more orgasms she has, the more oxytocin will be released, the more bonding will be there between a man and a woman. Clear? This is the reason. See, oxytocin, it is also called as cuddling hormone, the love hormone, right? The reason being, this cuddle chemical, it is released, which helps in bonding. Am I clear? So, during coitus, once more you are satisfied, more orgasms you will be having, more oxytocin is released, more bonding occurs. Clear? And during suckling of the milk also, oxytocin is released. Am I clear? Once your baby suckles the milk, oxytocin is released, which also causes bond formation between you and your child. Clear? Once oxytocin is released, oxytocin, it acts on the uterus and it causes contraction of the uterus. Am I clear? Oxytocin effect. Clear? As well as oxytocin, it causes contraction of myoepithelial cells of this breast and it can lead to milk ejection. Milk will be ejected out. Clear? This slide is clear, right? So coming to the mechanism of action, oxytocin, it binds to G protein coupled receptors, which are nothing but GQ receptors, stimulates phospholipase C, which causes conversion of phosphatidyl inositol 4,5. It's not diphosphate, it's bisphosphate, my dear students, because 4,5 position you have phosphate, right? So it is called as bisphosphate. It is not diphosphate. So this PIP2, it will be converted to IP3 and DAG. Am I clear? This IP3, it enters inside the cell. Am I clear? And it causes more and more release of calcium from your endoplasmic reticulum. Once calcium is more and more released, as well as it causes depolarization, induced activation of voltage sensitive calcium channels. So more and more calcium will enter the cell. Then what happens? More and more calcium, more and more contraction. Clear? As well as this oxytocin, it also causes more and more production of prostaglandins, especially PGF2 alpha, PGE2. Okay? Because of which there will be contraction of pregnant uterus. Also remember, my dear students, say non-pregnant uterus, it is resistant to oxytocin. It is not sensitive to oxytocin. Non-pregnant uterus, it is not sensitive. It is resistant to oxytocin. Am I clear? As the pregnancy progresses in the second trimester, as well as in the third trimester, what happens is there will be increase in the levels of receptors. The number of receptors will be increased, because of which the sensitivity of the uterus towards oxytocin will be increased. Am I clear? Am I clear? As well as estrogen, it increases the sensitivity of uterus to oxytocin. Progesterone, it reduces the sensitivity or increases the resistance to oxytocin. Progesterone, it inhibits the sensitivity of uterus towards oxytocin. Estrogen increases the sensitivity of uterus to oxytocin. Progesterone reduces the sensitivity of uterus to oxytocin. Please remember these concepts, my dear students. As we have already discussed, on the breast, it causes contraction of the myoepithelial cells, which leads to milk ejection, my dear students. Next, upon the kidney, it has got ADH-like activity. Am I clear? If you're giving in high doses, it has got ADH-like activity. Normally, it has got weak ADH activity. If you're giving in high doses, then what happens? There will be more antidiuretic effect. Am I clear? Once you're administering more and more fluids along with oxytocin, then it leads to water intoxication, my dear students. Clear? As well as upon the cardiovascular system. Upon the cardiovascular system, it leads to dilation. Am I clear? On the cardiovascular system, it leads to dilation, vasodilation, which can lead to reflex tachycardia. So reflex tachycardia can occur. Am I clear? Oxytocin, it causes dilation of your blood vessels. The reflex action is tachycardia. Clear? Next is carbitocin, which is an analog of oxytocin, which is a structural analog of oxytocin. It has got long duration of action. Next, we have got ergot derivatives, ergometrin or ergonovin, as well as methyl ergometrin or methyl ergonovin, also known as methergin. Upon the uterus, see what they do is they cause contraction followed by relaxation of the uterus. Am I clear? They increase the force of contraction, they increase the frequency of contraction, they increase the duration of contraction. Am I clear? If you're giving in low doses, then what happens is they cause contraction followed by relaxation. If you're giving in high doses, they can lead to uterine tetany. Clear? Upon the GIT, they cause increased peristalsis. Am I clear? And on the cardiovascular system, they cause vasoconstriction. Clear? Next, coming to prostaglandins, we have got, as I have told the mnemonic, your mis comes first. So PGE1 analog is misoprostol and PGE2 analog is dinoprostone. Am I clear? PGE1 as well as PGE2, what they do is they cause ripening of your cervix as well as dilation of the cervix, which leads to induction of labor. Clear? This is clear, right? Oxytocin, it can be used to induce labor. You can use in postpartum hemorrhage, PPH. For the prevention, IM you can give or IV infusion. You can give, and for the treatment, you can give as IV infusion. See, what it does is oxytocin, it constricts all these drugs, they can be used in PPH. These drugs, what they do is they cause contraction of the uterus. Am I clear? Uterine muscle will be contracted. See, the blood vessel, it is passing like this. Through the muscle, it will be passing, right? Once this is constricted, once the contraction of the muscle occurs, then the blood vessel will be compressed. Once the blood vessel is compressed, can blood flow occurs? No, it doesn't occur, right? So you can use in postpartum hemorrhage. Am I clear? Intranasally, you can give oxytocin for breast engorgement. Clear? You can also use carbitocin for the prevention of uterine atony following cesarean section. You can use. You can also use in PPH. All these drugs can be used in PPH case. Ergometrin as well as ergonovin also you can use in postpartum hemorrhage. Prophylactically, after delivery of anterior shoulder, you can give methyl ergometrin, which is more potent when compared to ergometrin. You can give, for prophylactic purpose, 0.2 mg. IM you can give to prevent postpartum hemorrhage. You can also give IV 0.2 mg in acute cases. In postpartum hemorrhage, you can give, as well as you can also give ergometrin plus oxytocin also can be given for postpartum hemorrhage. After cesarean section, you can give methyl ergotamine to prevent uterine atony, as well as to control bleeding also, you can use methyl ergometrin. Clear? Ergometrin as well as methyl ergometrin can be given orally to hasten the involution of uterus when it is delayed. Clear? Misoprostol as well as carboprost, what they do is they cause contraction of your uterus. because of which the blood vessels will be constricted. So you can use further treatment as well as prevention of postpartum hemorrhage. Am I clear? Next is misoprostol. Also you can give by oral route, you can give, as well as sublingually you can give. Carboprost can be given by intramuscular route. Clear? So this is all regarding the uses of uterine stimulants. Clear? Also known as oxytocics, also known as ecbolics. Clear? This is clear, right? Next, coming to adverse effects and contraindications. If you're giving in high doses, overdosage leads to uterine rupture, as well as because of more and more contraction, it leads to fetal asphyxia as well as fetal death can occur. Water intoxication, if you are administering fluids along with oxytocin, it can lead to water intoxication, which can lead to headache, vomiting, drowsiness, as well as convulsions because of oxytocin having ADH-like activity. Clear? It has weak ADH activity. If you're giving high doses, it can lead to water intoxication, my dear students. High doses, if you're giving, as we have already discussed, it leads to vasodilation, which leads to hypotension and reflex tachycardia can occur. Clear? Next is ergometrin as well as methyl ergometrin. These drugs, they cause nausea, vomiting, rise in BP, especially in hypertensive patients, because as I have discussed, they cause vasoconstriction, right? So these drugs, they raise BP in hypertensive patients. Clear? So you should not give these drugs in hypertensives. You should not give these drugs in, these drugs are contraindicated in hypertension. Peripheral vascular disease. Peripheral vascular disease, what happens? See, for example, in the periphery, there will be a single artery. End arteries will be there, right? Am I clear? If the end arteries or there is a single artery which supplies blood, if you are compressing it, then what happens? Blood flow will not be there. There will be tissue damage, right? Gangrene occurs. Cell death because of cell death, because of lack of blood flow. So these drugs, they are contraindicated in peripheral vascular disease. Am I clear? There are also these drugs, ergometrin, methyl ergometrin. These drugs, they are also contraindicated in sepsis, preeclampsia, as well as eclampsia. Clear? You can't use these drugs. These drugs, they interfere with lactation because they cause blockade of prolactin release or secretion. Prolactin release or secretion will be reduced, because of which they interfere with lactation. Clear? This is clear, right? Next kind of tocolytics, oxytocics or uterine stimulants is completed. Now we'll discuss regarding tocolytics, drugs which cause uterine relaxation. See, as you can see over here, this is your myometrium. Am I clear? Beta 2 agonists, if you're giving beta 2, they're present in your uterus, right? What happens? These are GS coupled receptors. Because of stimulation of these receptors, there will be stimulation of adenylate cyclase, which converts ATP to cyclic AMP. Once there is more cyclic AMP, it causes increase in the levels of protein kinase A. Protein kinase A will be activated, which leads to reduced calcium influx. No calcium influx, reduced calcium can lead to relaxation of your uterus, my dear students. Clear? Next is nitric oxide donors. Nitric oxide, it causes activation of guanyl cyclase, which converts GTP to cyclic GMP, which causes uterine relaxation. Because of increased levels of cyclic GMP, what happens? There will be activation of protein kinase Z, okay, which can lead to uterine relaxation. Clear? As well as CCBs, calcium channel blockers like nifedipine, as well as magnesium sulfate is one more, but it's not actually CCB. It does not come under the classification of CCB, but it still can inhibit calcium influx. Only nifedipine is the CCB, calcium channel blocker. Okay, once influx of calcium is inhibited because of the blockade of calcium channels, then what happens? There won't be contraction. Clear? Relaxation can occur. As well as we also have discussed oxytocin, it causes contraction of the uterus by acting on oxytocin receptors, right? Which are G protein coupled receptors. Just now we have discussed, right? If you're blocking these receptors, then what happens? Oxytocin cannot act. If oxytocin cannot act, then what happens? It leads to uterine relaxation, my dear students. Am I clear? Etosiban is a drug which blocks these oxytocin receptors. Once oxytocin receptors are blocked, oxytocin cannot act. If it cannot act, there won't be any uterine contraction, uterine relaxation occurs. Clear? Next, indomethacin, which is a COX inhibitor. Indomethacin is nothing but NSAID, non-steroidal anti-inflammatory drug, guys. Indomethacin, it is a COX inhibitor. Once COX is inhibited, then what happens? Prostaglandin synthesis will not be there. If there are no prostaglandins like PG, E2, PG, F2 alpha, then what happens? There won't be contraction of the uterus, so relaxation of the uterus occurs. Clear? All the mechanisms of actions are clear, I guess. So I'll proceed to the next slide. Hope this slide is clear. Coming to uterine relaxants, we have got beta agonists. We have got selective beta agonists, beta 2 agonists like isoxaprine. We have got salbutamol, terpidolin, as well as ditodrin. They increase the levels of cyclic AMP, which activates protein kinase A, which leads to reduced calcium influx, which leads to relaxation. Clear? Of course, CCBs as well as magnesium sulfate, these also cause inhibition of calcium influx by blocking calcium channels, okay, in the myometrial cells, which leads to relaxation. As we already discussed, etosiban, it competitively blocks oxytocin receptors, because of which oxytocin cannot act on the receptors, because of which there will be uterine relaxation, my dear students. If you're giving NSAIDs like indomethacin, it inhibits COX. Once COX is inhibited, there won't be conversion of arachidonic acid to prostaglandins. Clear? No prostaglandins, no contraction, relaxation of the uterus occurs. Indomethacin, it can be used because it has got tocolytic effect. Magnesium sulfate, if you are giving IV infusion, it has got depressant effect on uterus, that is uterine smooth muscles, on your CNS as well as on your myocardium. It has got depressant effect on all these. Progesterone, as we have already discussed, progesterone, what it does, it relaxes the uterus, as well as it can relax the uterus, as well as it also reduces the sensitivity of uterus to oxytocin, because of which once the sensitivity is reduced, resistance occurs, right? Because of which uterine contraction won't be there, uterine relaxation occurs. Nitric oxide downwards, because of increased levels, this nitroglycerin and other nitrates, they have a tocolytic action, because once nitric oxide is released, converts guanyl cyclase to cyclic GMP, which can activate protein kinase Z, am I clear? Which leads to uterine relaxation. And we have got other drugs, halothane, which is a inhalational general anesthetic. which also can cause uterine relaxation. So these are all the drugs which cause uterine relaxation, my dear students. Clear? Last but not the least, coming to the uses of these drugs, you can use in to delay preterm labor whenever before 9 months. If there is labor, you can give these drugs to delay preterm labor. Clear? Threatened abortion. For threatened abortion, you can use this progesterone can be used. Remember T for T. Progesterone, threatened abortion. Clear? Dysmenorrhea, you can use indomethacin can be used. Am I clear? Prostaglandin synthesis inhibitor or COX inhibitor or NSAID indomethacin can be used for dysmenorrhea. Clear? Hope all the slides are clear. If you want to learn more, please subscribe to our app, the Prakara app. See you in next webinar. Thank you, guys.